Dear friends, welcome to this very important RSSDI national program, and which is delivered by Rajasthan chapter of RSSDI. And the purpose of this particular program is very different, as we want to train most of you people regarding the RSSDI wheel. And for this, none other than we have a very senior endocrinologist of our Rajasthan, our state, and he is one of the acclaimed speaker faculty for not only national but international acclaimed faculty, Dr. S.K. Sharma sir. Before this, I want to give you just little bit about why this national program was launched. This particular national program for the training of RSSDI wheel was launched earlier, and we have already covered most of the districts of Rajasthan. And the purpose of this training regarding the RSSDI wheel is to make you people aware of the how to manage type 2 diabetes patients. And evidence-based medicine should be there, and not only the evidence-based medicine, but how to deal with a simplified manner. Just a simple wheel will guide you how to manage type 2 diabetes people. What are the different drugs, what are the different situations, and with the different situation, whether because you cannot go with one drug for the management of diabetes. There are so many defects, and you have to correct so many defects in type 2 diabetes patients. However, it is very individualized and personalized approach, and this is known as art of managing diabetes in type 2 diabetes patients. And that's why this RSSDI wheel was created by RSSDI ESI consensus guidelines. And you will be just after 2 or 3 minutes, Dr. S.K. Sharma sir will take care of and you will be trained regarding the RSSDI wheel. So, and this is not only you have to, be aware of that, but this is your duty to train your peers, not only in your periphery, but also CSC, also the primary health centers, and even I can say the physicians or doctors working in the sub centers. So they should be aware of the what is the current guidelines for the management of type 2 diabetes. So it is basically, if you will train those doctors, then definitely the management of diabetes will be much easier. So that at first instance, the doctor sitting in the sub center, primary health center, he will be very confident of treating or managing type 2 diabetes. And if not possible or uncontrolled situation or certain comorbidities, then and then he should refer these patients to you as a consultant or in the bigger cities. So at the first instant, they have to be well aware of how to manage type 2 diabetes. So this is the purpose of the whole program, which is known as RSSDI Train the Trainer program. And please train after this program, you have to train your peers in the periphery. So that is the thing. And now I request today's chairpersons, Dr. R.P. Parikh Sahab, who is a very senior person and president of API Rajasthan at present, and the doctor. Another is, who is the another chairperson?
VK Jain.
Yeah, Dr. VK Jain sir, another stalwart of our Rajasthan API. So both of you, please take care. Take this dais just now and invite Dr. S.K. Sharma sir for the today's program. So, Dr. Parikh sir, please.
Over to Parikh sir.
Sir.
Namaskar. Good evening to one and all. It's nice to see the colleagues from the Shekhawati region for this nice meeting, and The lecture we are going to listen is by our senior most person in endocrinology, Dr. S.K. Sharma, who is a well-known figure in this area. So no introduction for him, but still he was a senior at SP Medical College, Bikaner. Then he did his DM from PGI Chandigarh. He was in SMS for quite some time. And now he's a leading endocrinologist in Jaipur. So the wheel, which he is going to talk about, would be very useful to all of us. And I think we should not waste time. I welcome Dr. S.K. Sharma, sir, to kindly start his talk.
Thank you, Dr. R.P. Parikh sir, Dr. Arvind Gupta, Dr. Ramchandani, and so many of our friends. And in jokingly, I will say, ये मेरा इलाका है. यहाँ कोई दूसरा. जैसा कि पारिक साहब कह रहे थे. So dear friends, now coming to the serious business of diabetes, as we all know, type 2 diabetes is a serious disease. It is a disease which is characterized by complications. And in India, we have a huge number of diabetic patients. And an important point is that two diabetic patients are not similar. That is a very important point. So you have to look into the characteristics of the patient who is sitting in front of you. And then you realize or decide what are the different components of his disease. There are multiple factors related to the disease of the patient. There are multiple factors which are patients related, and then identifying those factors and then selecting the pharmacotherapy for that patient, which is accurate, or you can say correct in science. So diabetes is a heterogeneous condition. That is very important message which we can say. And once we have a heterogeneous condition, you can't have one, you can say, point which is taking care of everything. So you have to decide, look into all the aspects of the diabetic patients, and then decide this therapy to the patients. So can you see my slides, sir?
Yes, sir.
Okay, thank you. So dear friends, today we are going to discuss this RSSDI and Endocrine Society of India combined clinical practice recommendation for the management of type 2 diabetes. So dear friends, this was published in one of our own Indian Journal of Diabetes developing in the developing countries. And here you can see this whole text, and you must have looked into this text, which we have downloaded in your WhatsApp group. Once we created that WhatsApp group, so this whole presentation is there. So dear friends, what are the contents of today's talk? Relevant factors to Indian context, indicating that in India, we have diabetes which is slightly different from other diabetes in other countries. So we Indians are different, and our diabetes is also a bit different from other countries. And what are the management of type 2 diabetes guidelines in our region, which will be, you can say, appropriate for our population, is to be highlighted. And then, of course, there is a ABCD EFGH approach, which indicates many of the features of our diabetes and diabetic patients. So we'll be discussing all these things in our next subsequent slides. So what are the factors which are relevant to the Indian context? In India, we have high prevalence of diabetes as well as pre-diabetes. Pre-diabetes, or you can say impaired glucose tolerance, is also very common. And in India, the conversion rate from pre-diabetes to diabetes is very, very high. So that's why there is a huge burden of diabetes, and this burden will remain there for next few decades also. So that's why we have a huge burden. Onset of type 2 diabetes is developing in our patients 1 decade earlier than the Western countries. So our patients are developing type 2 diabetes at the age of, let's say, 30, 40, as compared to what is happening in Western countries, where type 2 diabetes is developing in 50s and 60s. Secondly, our patients are having not only high prevalence of diabetes, but also high prevalence of diabetes-related complications. And once we say complication, it means microvascular complication as well as macrovascular complication. So our patients are developing more of retinopathy, nephropathy, and neuropathy, as well as accelerated cardiovascular disease, like in the form of acute myocardial infarction, stroke, or gangrene, peripheral arterial disease. We also have a large rural-urban divide, more commonly seen in our urban area, where you find that most of our cities are having higher prevalence of diabetes as compared to our rural area. But now the rural area is also showing higher and higher prevalence of type 2 diabetes. We Indians are having a sedentary lifestyle. So we are really not doing physical activity, even in our rural area. Now, motorcycle, tractors, and other, you can say, appliances are available, so that the physical labor is significantly reduced even in our rural area. So we are physically very inactive, you can say, ethnic group, and that's why it is very difficult for our, you can say, colleagues to enforce physical activity in our diabetic patient. We all know that diabetic patient require increased physical activity, but it is a bit challenging in our day-to-day practice. Now, cost of diagnosis, cost of treatment, and cost of monitoring and prevention of diabetes is also very high. So in our patients, most of our patients are spending from their pocket, and that's why it is sometimes very difficult for them to continue with a good treatment. And we have limited resources as limited resource to the patient, limited resources to the society, as well as limited sources to our, you can say, country. So in that context, looking into the management of diabetes is very important. So whenever we go for management of diabetes, the first important pillar is medical nutritional therapy and lifestyle modification, LMT. So dear friends, this is very, very important. Why it is important? Because 1 to 2% of HbA1c can be reduced with the help of a good medical nutrition therapy and lifestyle modification, as compared to 0.5% and 1% reduction in HbA1c by many of our anti-diabetic drugs. You can reduce the HbA1c to a tune of 1 to 2% with medical nutrition therapy and lifestyle. So nutritional counseling may be provided by healthcare provider who is not trained in a, you can say, dietetic nutritionist course, but basic concepts of nutrition should be known to our colleagues, so that they can, in a short time, give this medical nutrition therapy to our patients. Overall, reduced consumption of simple carbohydrate like sugar, like fried food, and higher consumption of complex carbohydrates are required. And our Indian diet is a bit poor in protein intake. So we have to look into protein intake also. And we have to recommend that we will be reducing the simple carbohydrate, sugar, jaggery, shahad, etc. And then we will be highlighting that we should be using more of complex carbohydrate and more of protein-rich substances in our meal. And salt is also very important, because we have to reduce the salt intake. Salt should be taken in moderation, because not only in diabetes, but diabetic patients are also having higher prevalence of developing hypertension and cardiac disease, and heart failure is also very commonly seen in our long-standing diabetic patient. So salt should be restricted, and we should encourage increased duration and frequency of physical activity whenever it is needed. It is needed in most of the patient. So we should always have some time to encourage our patient to stick to some of the physical activity. And mass awareness campaign for healthy diet and lifestyle should be conducted by all of us in our community, so that we can prevent the development of diabetes. And if the patient is diabetic, then they can take care of their diabetes with little amount of oral or other anti-diabetic drugs. So what are the recommendations for the medical nutrition therapy in patients with type 2 diabetes? So earlier we know that people were taking 60 to 70% of carbohydrate in their diet. But now the concepts are that we should be limiting our complex carbohydrate to 50 to 60% of the total calories you can say, coming from complex carbohydrate. Food with low glycemic index and glycemic load is preferred. Rice quantity should be limited, and if the patient prefer rice, then brown rice, in addition to other food substances should be encouraged, and fiber intake should be increased because we have a diet which is sometimes not rich in fiber. So fiber are very important and we should increase fiber in our diet. Next comes protein. 15% of total calories should come from protein, and consider other comorbidities like renal disease, hypertension, or you can say patients who are having other conditions. You have to modify the amount of protein in our diabetic diet, and limited red meat that is bad for our patients, cholesterol as well as lipid. So we should be limiting red meat, and we will prefer white meat, that is chicken and fish, if the patient is a non-vegetarian, and prefer other sources of proteins like pulses, legumes, etc. And then regarding fat, 30% of calories should come from fat. It should not be more than 30%. And we should have 2 or 3 types of oils, and we keep on rotating the oils. For example, a family requires 3 kg of oil in a month. So we should purchase 3 types of oil like sarson ka oil, mungfali ka oil, and olive oil. And we should not mix them. But in the morning, we are preparing our food with one oil, in the afternoon with other oil, and in the evening with third oil. So rotation of oil is always better, because most of these oils are having something which is good and something which is bad. So if you are only using one type of oil, then you will be having some problem. So rotation of oil is very, very important. And foods which are high in saturated fat must be avoided. So something like red meat is having high, you can say saturated fat. Similarly, coconut oil and palm oil are rich in saturated fat. That should be avoided. It should be less than 10% of the total calories coming from the saturated fat. And we should be avoiding hydrogenated vegetable oils. These are the hydrogenated oils like dalda. Okay, and then trans fats. Trans fats are also equally important. When you keep on boiling oil again and again, more and more trans fats are produced. Like when you are looking into some of these samosa kachori people, they keep on having boiling oil, and they keep on having that from the morning till evening. And that is the oil which is very rich in trans fats, which is increasing cholesterol and causing more of atherosclerotic cardiovascular disease. And diet should be rich in fruits, vegetables, and salads. Nuts, which are giving diet which is giving fiber, should be encouraged, like whole grains, and unsaturated fat should be included in our diet. So pulses, legumes, unprocessed vegetables, and low-fat dairy should be included in our diet. And as we discussed, salt should be in moderation, and artificial sweeteners can be taken if the patient is not pregnant, but that should be taken in moderation also. So this is a general guideline regarding the dietary modification in our patients. Next comes very important point, physical activity, exercise. So we usually say 150 minutes per week of physical activity is recommended, you can say in a week, and every day patient should be doing something like 30 to 45 minutes of moderate intensity aerobic activity. It should be combined with 15 minutes of muscle strengthening exercises, which will be producing important improvement in the muscle power and reducing the insulin resistance. And 15 to 30 minutes of work related activity like walking in the offices, going up and down in your office, and not using the elevators and walking the stairs. These type of activities are always good. And whenever we are sitting for a long time, like 1.5 hours or 2 hours, we should have a break of 5 to 10 minutes. During that time, we should be walking in the room, or whenever we are taking a mobile call, we should stand up from our sitting position, and they say, walk when you talk on your mobile. So these are some of the important guidelines. Now coming to the real topic of RSSDI, ESI, therapeutic wheel. The therapeutic wheel is nothing but a guideline for choosing particular type of drug in a particular type of our diabetic patients. So pharmacotherapy choices should be included here. So in this wheel, you can see there are different colored circles are there. In the center, there is a black point there, which is LSM, that is lifestyle modification, indicating that lifestyle modification is the central to the therapy of type 2 diabetes. Next comes a area which is marked as metformin. And we all know that in type 2 diabetic patient, metformin is considered as the first choice of oral anti-diabetic drug, except in advanced renal disease. And that's why in C stands for chronic kidney disease. And there you can see there is a cut there in metformin, indicating that in advanced chronic kidney disease, we should be avoiding metformin. Then there is a circle which is marked by A, B, C, D, E, F, G, H. And this A, B, C, D, E, F, G, H indicates A stands for advancing age, B stands for BMI, that is increasing BMI, C stands for advancing chronic kidney disease, because we know that 30-40% of our type 2 diabetic patients after many years of diabetes will develop chronic kidney disease. D stands for duration of diabetes. So you have some patient who is having a short duration of diabetes, other are having 10 years of diabetes, and other patient is having 20 years of diabetes. So selection of your drug will be depending upon duration of diabetes also. E stands for established atherosclerotic cardiovascular disease, that is cardiovascular disease, whether they are having low risk of cardiovascular disease or high risk of, or they have established cardiovascular disease, that the patient is having risk factor for cardiovascular disease in the form of obesity, hypertension, dyslipidemia, and a strong family history of cardiovascular disease. Or you can see that patient already had a MI or a stroke or a peripheral arterial disease. So that is E. E means established cardiovascular disease. F is also important in Indian context. It indicates finances, meaning by the patient is having adequate finances or he is having limited finances. Because in Indian context, many of our patients has to spend from their own pocket. And that's why finances are also important. G stands from glycemic status, indicating that you have a patient with mild hyperglycemia. HbA1c is only mildly elevated. Other patient is having severe hyperglycemia. HbA1c is 11, 12, 13, something like that. So accordingly, you will choose a drug which is targeting either a lower HbA1c or a higher HbA1c. In higher HbA1c, we all know that usually we give combination of oral anti-diabetic drug right from the beginning. And then H stands from a very important point, that is hypoglycemia. H stands for hypo. There are some patients who are having hypoglycemia, and you have patients who are developing recurrent hypoglycemia. And in them, we usually avoid drugs which causes hypoglycemia like sulfonylureas or insulin, or we will be very, very careful in selecting sulfonylurea, like lower doses of sulfonylurea, and selecting insulin in such a way that patient will not develop hypoglycemia. So this is A, B, C, D, E, F, G, S. Dear friends, if you see the green circle, it indicates that the patient is having most of the time no problem. So he is a newly diagnosed, you can say, or a short duration of diabetes, having no renal or cardiac problem. And here you are having all the available anti-diabetic agents, and you can choose according to the patient's characteristic. So most of the drugs can be given in this type of patients who are falling in green circle. Then yellow circle means you have to apply some of the precautions, because now the disease is developing into more chronic kidney disease, more advancing, you can say, obesity, more advancing duration of diabetes, or more atherosclerotic cardiovascular disease, or you can say less finances, etc. So here you find that in yellow area, you have so many drugs which are marked there, like DPP-4 inhibitor, AGI, alpha glucosidase inhibitor, pioglitazone, sulfonylurea, etc. And here they say you choose according to hierarchy is according to the clockwise direction. So for example, if you look into A, advancing age, so in elderly patient, the preferred drug is DPP-4 inhibitor. So if you look into A and you go to the yellow circle, you find that DPP-4 inhibitor is the first according to the clockwise direction. So, and then comes AGI, then comes SGLT2, and then pioglitazone, and then in the end you find that sulfonylurea and insulin, because we know that elderly patients will have more chances of hypoglycemia, and that's why this sulfonylurea and insulin are in the end. So hierarchy of drug selection is according to the clockwise direction. That is important. And in the red circle, which is the last circle, these are the patients who are having more severe problem, like more chronic kidney disease, more advancing, you can say BMI, less finances, or more atherosclerotic cardiovascular disease, etc., or very long duration of diabetes. And here you have to again select some of these drugs according to the clockwise direction again. But here you find there are fewer lesser drugs available, because some of the drugs you can't keep them in this advancing diabetic patients. So this is what we say a therapeutic wheel in our RSSDI ESI guidelines. So individualization of therapy is very, very important, because no two patients are similar. You have a young patient, you have an old patient of diabetes, you have a lean and thin patient, you have an obese patient, you have a patient with no chronic kidney disease, estimated GFR is more than 90, other is having estimated GFR less than 30. You have a patient of short duration, a long duration. One patient is having no atherosclerotic cardiovascular disease, other is having pre-existing myocardial infarction or stroke. Some is rich, some is poor. Some is having mild elevation of hyperglycemia, other is having severe. And one patient is recurrently having hypoglycemia, other is not developing hypo. So these are some of the characteristics of our diabetic patients. And according to these characteristics, you look into the patient's profile and look into these points about A, B, C, D, E, F, G, H, and accordingly you will select a appropriate oral or injectable therapy. So dear friends, individualization of therapy is very, very important. Choice of any OLD should be considered when you have a patient who is having good general health, short duration of diabetes, and having no associated disorder. But once you have a patient who is having many of these concerns, what we discussed, then you have to select these patients according to the characteristic of that patient. You have to select the appropriate drug. And for any type 2 diabetic patient, we all know that the first line of therapy is metformin. 5 to 10% of our patients may not be tolerating metformin. And there you have to choose the next drug, whether it is a sulfonylurea or DPP-4 inhibitor or SGLT2. It all depends upon the characteristics of the patient and the duration of diabetes and other features. So dear friends, let's come to the A. That is the first point, advancing age. So here you will see on the left side, large number of drugs are enumerated, like sulfonylurea. Today we are only using modern sulfonylurea in the form of glimepiride and glycoside modified release. Next is DPP-4 inhibitor like sitagliptin, saxagliptin, tenaligliptin, linagliptin, etc. And AGIs are alpha glucosidase inhibitors like voglibos or acarbose. Then SGLT2 inhibitors, we have dapagliflozin, empagliflozin, and canagliflozin. And then glitazones, that is only one drug is there, that is pioglitazone. Basal insulin analogs are now available like glargine, glargine U300, and Tresiba is also available. And then GLP-1 receptor agonist in the form of liraglutide and semaglutide will be available shortly. So these are some of the drugs. And if you look into their characteristics, you find that some of these drugs can be used in many of these drug patients. Some of the drugs causes hypoglycemia. Some of the drugs are to be avoided in renal problem. Some of the patients should not be given glitazone. For example, pioglitazones are contraindicated in our patients who are elderly ladies, who are having heart failure, and who are having advancing chronic kidney disease, because they causes fluid retention, precipitation of heart failure. And in our post-menopausal lady, they cause osteoporosis and fractures. That's why pioglitazone should be avoided in post-menopausal ladies. So you can see these are the drugs which are available to us and we had to choose them. The B stands for advancing BMI, that is increasing BMI. And here you can see some of the drugs are causing weight loss like SGLT2 inhibitor and GLP-1 receptor agonist. Some of the drugs are weight neutral like AGIs and DPP-4 inhibitors. And some of the drugs may cause weight gain like insulin and older sulfonylureas, and modern sulfonylureas either do not cause weight gain or a very minimal weight gain like glimepiride and glycoside extended release. Next comes C. C is important because C stands for chronic kidney disease in our diabetic patient. We know that 30 to 40% of our type 2 diabetic patients develop CKD, and as the year advances, more and more patients will develop CKD. So here are some of the drugs which are preferred in our patients with CKD like SGLT2 inhibitors and GLP-1 receptor agonists. But once the patient's estimated GFR is less than 30, we can use SGLT2 inhibitors, and there we will be using only GLP-1 receptor agonist or insulin, because GLP-1 can be used till a estimated GFR of 15. So here I can see Dr. Parikh sir has also joined us. So welcome to Dr. KK Parikh sir, and I will stop here and we will take Dr. Parikh's opinion, then we will continue. Dr. Parikh, you can unmute yourself.
Sir, thank you so much, sir. It's really a wonderful talk, and you are very much busy. One time you are there in Deticon, and now you are here. It's really a great dedication and sincere work for you. And I think we have learned a lot of things. And this Deticon had been also a wonderful discussion and wonderful program. We have discussed many things.
I was looking into the second laptop, yes, sir. So there was many questions and many comments there.
Yes.
People had enjoyed it. Yes. Thank you, sir. So we can continue, sir. So we were discussing this wheel, sir. So we reached to the C. C stands for chronic kidney disease. And here we say that some of the drugs are preferred in chronic kidney disease like SGLT2 inhibitors and GLP-1 receptor agonists. But once the estimated GFR is below 30, we should not use SGLT2 inhibitors, but we can use GLP-1 receptor agonists till a estimated GFR of 15. But in most of the time, what we do, we select insulin. It may be a very low doses of insulin, but in advanced kidney disease, usually we give insulin. Some of these DPP-4 inhibitors in modified doses, in reduced doses, can be given in patient with CKD. For example, sitagliptin can be given 50 milligram once a day. Vildagliptin, which we use 50 milligram twice a day, can be given 50 milligrams once a day in CKD patients. Okay. Then SGLT2 inhibitors are indicated to improve the glycemic control in adults with type 2 diabetes by reducing and the resorption of filtered glucose. So glucose is filtered from the Bowman's capsule, and this glucose is not reabsorbed because you have blocked the SGLT2 receptors by a SGLT2 inhibitor. And that's why there is a loss of glucose in the urine. Every day, patient is passing something like 70 to 80 grams of glucose in the urine. And that's why urine of these patients on SGLT2 are 3+ or 4+. And that is the cause of a recurrent genitourinary mycotic infection also. And that's why we prefer that these patients should be having good genital hygiene. And we prefer that they should be taking extra water, 2 or 3 glasses of extra water in the day. With that background, if you look into drugs like metformin, metformin can be given till a estimated GFR of 45 or more. Once estimated GFR is less than 45, but more than 30, we have to reduce the doses of metformin to half. That is maximum 1000 milligram per day. Okay, once the estimated GFR is below 30, we have to stop metformin. So this is the important caveat regarding metformin, that we have to stop metformin once estimated GFR is below 30. And if it is less than 45, we have to reduce the doses. and we have to monitor the therapy more frequently. Like we will keep on monitoring creatinine and albumin urea every 3 months or so. Short-acting sulfonylurea in lower doses like glipizide and glycoside can be given in patients of chronic kidney disease. AGIs can be given in mild to moderate, but not in severe renal disease. Once the creatinine is more than 2 milligram, we should avoid alpha glucosidase inhibitors. And DPP4 inhibitor, as we discussed, can be given in most of these patients, but you have to modify the doses except linagliptin. So you don't require modification of linagliptin dose, but you can continue with linagliptin same 5 milligram per day. But other DPP4 inhibitor like sitagliptin and vildagliptin, you have to modify the doses and give in a lesser amount. And we discussed that pioglitazone should be restricted in advanced renal disease. Ripaglinide should be carefully given because it may lead to hypoglycemia. And we already discussed SGLT2 inhibitor because they are good drug, because these SGLT2 inhibitors, you can say, retard the progression of chronic kidney disease in our diabetic as well as non-diabetic patient. But once it is below 30, we have to reduce the, you can say, stop the SGLT2 group of drugs. GLP-1 receptor agonist like liraglutide, and now within a short period, oral semaglutide will be available to our patient, can be given till a estimated GFR of 15. And insulin is considered to be the good choice in advancing renal disease. The only point is that you will be giving less doses and you will be keeping a very close watch on hypoglycemia, because once the patient is having CKD, the chances of hypoglycemia is very, very high. So with that, we comes to D. The D stands for duration of diabetes. So from short duration, patient is now going into longer duration. So there are some drugs which can be given in most of the time, like drugs which are insulin independent, that drugs like SGLT2 inhibitors, alpha glucosidase inhibitor, and sometimes GLP-1 receptor agonists are considered to be a good drug for a long duration of diabetes treatment. But right from the beginning, we should go for a tighter control. Why we want tighter control? Because there is a positive legacy effect. And there are studies like UKPDS and studies like type 1 diabetic patient study, which clearly indicates that if you have a tighter control right from the beginning, and then after few years of diabetes, even if there is a deterioration in hyperglycemia, the chances of developing complications are very, very less. And that's why we say tight control right from the beginning is required for a very good positive metabolic memory. And that's why many a times our patients are on these sulfonylurea and metformin, which are considered to be a potent drugs. And right from the beginning, they give you a very good control. And that's why you are using most of the time these combination of sulfonylurea and metformin. But important point is we should be controlling hyperglycemia right from the beginning. Again, you can see UKPDS is telling us about the legacy benefit. So in UKPDS, what happened? They have divided the patient into two arms, conventional arm and intensively treated arm. And there was a difference of 0.9% between the two arms. After stopping of the study, after 7 years or so, now the patients were having a similar HbA1c. But what happened? Even after similar HbA1c, those patients who are on intensive arm earlier are having less complications as compared to those patients who are in conventional arm having higher HbA1c right from the beginning. That is why we say that we should go for a legacy effect, and that's why we say right from the beginning, good control of hyperglycemia is required. Dear friends, E stands from established cardiovascular disease. In patients with diabetes, there are few established cardiovascular disease, and here two group of drugs, GLP-1 receptor agonist and SGLT2 inhibitors, are having proven efficacy, and these drugs are preferred. Whether you look into ADA guidelines or European Society guidelines, you can always say that these two group of drugs, SGLT2 and GLP-1 receptor agonists, are always preferred in patients who are having pre-existing atherosclerotic cardiovascular disease, or those are having higher risk of atherosclerotic cardiovascular disease. Who are at higher risk? Long duration of diabetes, patients suffering from target organ damage, hypertension, dyslipidemia, etc., or strong family history, or having smoking. So these are the patients who are having higher risk of cardiovascular disease, and there you prefer either a GLP-1 receptor agonist like liraglutide or semaglutide, or you prefer SGLT2 inhibitor like dapagliflozin, canagliflozin, or empagliflozin. There, in some of the studies, pioglitazone was also shown to have reducing cardiovascular disease. But here, important point is that you have to differentiate between the cardiovascular disease and heart failure. In cardiovascular disease, pioglitazone has positive, good effect. But in patient with heart failure, it is a bad drug because it causes fluid accumulation and precipitation of patients who are having reduced ejection fraction. That's why we avoid pioglitazone in that type of patient. Linagliptin, glimepiride, and glycoside can be preferred over a conventional sulfonylurea in patients who are having established cardiovascular disease, because you know that in many of these studies, these newer, or you can say smart sulfonylureas like glimepiride and glycoside are showing, you can say, no harm to the cardiovascular system. And in linagliptin, you can have Carmelina and Carolina trial, which was showing some positive effect on cardiovascular outcome. Dear friends, F stands from financial concerns, because many of our patients has to purchase their drugs from their pocket, and many of them are not having this insurances, etc., which is very strong in Western countries like USA. In UK, most of the time healthcare is free of cost. It is provided by National Health Services. But in India, we have a khichdi of system. We are having government hospitals, we are having private hospitals. Few of our patients are having insurances. Many of our patients are having no insurances. And that's why they have to pay from their pocket. And we have to consider what is the financial status of the patient. And that's why we have to look into what are the drugs which are economical, like metformin, sulfonylurea, and some of these generic DPP-4 inhibitor. And now some of these SGLT2 inhibitor are now, you can say, generic, and they are economical. Then pioglitazone is also economical in Indian context. That's why we are many times using pioglitazone. But whenever we are using pioglitazone, we are using them in a lower dose, like 15 milligram once a day. We usually avoid using higher doses of pioglitazone. Okay, that is very important message here. So financial constraints are also very, very important. There is some artificial line there created by one of our colleagues. So I don't think it is good idea, but we will continue. G stands for glycemic status. And here important point is, what is the HbA1c of the patient, how high is fasting, and how higher values of postprandial. So there are some drugs which are very potent in reducing hyperglycemia, like insulin, GLP-1 receptor agonist, and SGLT2 inhibitors. Some of the drugs are moderate in their intensity of reducing hyperglycemia, like pioglitazone, DPP-4 inhibitor. So sulfonylurea, metformin, and GLP-1 are stronger. Moderate are SGLT2, pio, and DPP-4 inhibitors, and some are milder, like AGIs and glinides. So according to the potency of the drug, you can choose once you have a patient with very high hyperglycemia. If milder hyperglycemia, you can always have a drug like milder drug like AGIs or DPP-4 inhibitors. So that is important. And many times what we do, if the baseline HbA1c is more than 9%, we start the therapy with two drugs, two oral antidiabetic drugs like sulfonylurea and metformin, like metformin and DPP-4 inhibitor, or like metformin and SGLT2 inhibitors. So combination therapies are now preferred in our patient who are having higher hyperglycemia. Dear friends, last point is H. H stands from hypoglycemia. And we know that many of our patients are having recurrent hypoglycemia. Diabetes is a disease if a patient takes drug and avoid meal or do some more physical activity, he may have always development of hypoglycemia. And that's why we have to be very, very careful about hypoglycemia. So we have to tell the patient what is hypoglycemia, what are the symptoms of hypoglycemia, so that patient and his family member can identify hypoglycemia and they can manage hypoglycemia. That is important. So some of the drugs like insulin, sulfonylurea are potently hypoglycemic. They cause more hypoglycemia. Some of the drugs do not cause hypoglycemia, like DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists. So, and pioglitazone also. So you have to select the patient accordingly, and symptoms and signs of hypoglycemia at every visit you should be inquiring, and patients along with their family members should be, you can say, educated about hypoglycemia. And particularly nighttime hypoglycemia is also very, very important, because that is the time patient may not be able to recognize hypoglycemia. And in that patient, morning, you can say headache, morning sweating, and you will find that patient is having very poor sleep, and you can say bad dreams, which will indicate that patient probably had nocturnal hypoglycemia. And in patients who are having frequent hypoglycemia, like our elderly patient during pregnancy, or those who are undergoing fasting, like Indians are having many times having fasting, like Jain fasting or Hindus festival fasting or Ramadan fasting. So you have to be very, very careful in choosing drugs so that you can avoid a drug which is causing more hypoglycemia. If a patient is having chronic kidney disease, again, that is a point where you will find more hypoglycemia. So dear friends, these are the drugs like insulin, which causes hypoglycemia. Sulfonylurea may cause hypoglycemia, but some of the drugs like DPP-4, AGI, and SGLT2 and pioglitazone do not cause hypoglycemia. And that's why in these elderly patients, we usually prefer metformin and pioglitazone, or metformin and AGI, or you can see GLP-1 receptor agonist. So dear friends, we finished this therapeutic wheel, where we discussed this wheel right from the center to out. Lifestyle modification is most important. First drug is metformin. Then we divide our patient's characteristic according to the A, B, C, D, E, F, G, H. And then we select any drug of these in yellow patients, in green patients, sorry. In yellow circle, we can have some of the preferences. And in red circle, you will have lesser drugs which are available, because these are the patients who are having more, you can say, more advancing diseases, more advancing cardiovascular disease, long duration, more chances of hypoglycemia, and less finances. So you have to select the drug accordingly. So hierarchy of therapy is depicted in the clockwise manner. So you have to go in each area according to the clockwise direction. That is important. So when you see a patient in your clinic, prescribe lifestyle intervention to all your patients, like diet and exercise, and look at cardiovascular factor reduction like hypertension, obesity, dyslipidemia, and smoking. Metformin is the most important drug right from the beginning. It is the core drug, you can say, in the wheel. Identify 2 or 3 important concerns like advancing age, or finances, or pre-existing atherosclerotic cardiovascular disease, or very long duration of diabetes. That is how you will look into the concern of the patient, and you will be deciding which drug is good for that particular patient. Identify the best choices available to our patient in the outer ring, because those are the patients who are having more advanced disease, advanced criteria, you can say, and make a rational final choices with individualized approach. So some drugs are preferred in elderly patients, some are preferred in our economically challenged patients, some drugs are preferred in cardiovascular disease and diabetes patients. So accordingly, you will be looking into the characteristic of the patient, and you are selecting these, you can say, particular drug. An important message in the end is that try to avoid complementary and alternative medicine like Ayurveda, naturopathy, Siddha, Unani, homeopathy, etc., acupressure, etc. So physicians, diabetologists, and registered dietitians who are trained to practice in the modern allopathic system of medicine should not prescribe all these complementary and alternate medicine. That is important message. Don't do a khichdi of the pathies, and should not replace conventional modalities of treatment, what we discussed right from the lifestyle modification, diet and exercise, metformin, and then selecting the drugs according to the characteristics of the patient. So dear friends, in the conclusion, management of type 2 diabetes has substantial effect on the individual and societal health, psychological well-being, and quality of life, as well as economical repercussions. So you have so many factors there to look into in a diabetic patient. Diabetic management planning should be individualized. A precision medicine is to be given, and not a one-size-fit-all treatment pattern for patient with type 2 diabetes is there. So you can't prescribe similar type of drugs to your young patient, old patient, long duration of diabetic patient, and short duration of diabetic, no cardiovascular disease and cardiovascular disease. So you have to select the patient. The problem now is that earlier there was only 2 or 3 drugs, metformin, sulfonylurea, and insulin. But now you have more than 15 group of drugs. So how smartly you will select the drug and how smartly you will combine the drugs in that particular patient is a very, very important message. And diabetes is having multiple pathophysiological defects, what we say ominous octet, right from the decreased insulin secretion, increased insulin resistance, increased hepatic glucose output, renal problem, hepatic problem, cardiovascular problem, lipid problem. So you have to look into wholesome. So comprehensive management plan is important. You have to not only treat hyperglycemia, but also treat hypertension, dyslipidemia. Most of our type 2 diabetic patients should be on a lipid lowering drug like statin. So in my practice, 99% of my patients are on lipid lowering statin. Why? Because guidelines says that our diabetic patient should be having a total LDL of less than 100. If he is having a cardiovascular risk, it should be less than 70. And if he is having already a pre-existing myocardial infarction or stroke, the LDL should be less than 50 milligram. And that's why 99% of my patients are on statin. Okay, it may be a moderate intensity statin, or it may be a high intensity statin. So individualized therapy could serve as a real world approach, and you have to do some, you have to be waiting for 1 or 2 minutes in discussing and you can say selecting a particular good group of drugs which is good for that patient. That is the important message in this diabetic therapeutic wheel. So thank you very much. I can unshare my slides and we can always discuss what are the different questions and comments our friends are having. Thank you very much.
You can unmute and can ask any question because every stalwart is here and you can ask any question. Please.
We can take the opinion of Dr. Parikh also.
Yes.
Congratulations, Dr. S.K. Sharma, for a brilliant talk. A very nicely explained therapeutic wheel for the management of type 2 diabetes. And I think our primary physician, if they see this and observe this therapeutic wheel, they can very well control diabetes at their own level. And this is what RSSDI wants, that at the all primary physicians at their level, they can treat type 2 diabetic patients with the use of this therapeutic wheel. They should keep this therapeutic wheel on their consultation table so that whenever there is a problem, you can see the therapeutic wheel. So excellent lecture, Dr. S.K. Sharma. You had been, and I must congratulate that you have kept this Daticon time 8 to 9 so that we are all free and can attend this webinar in maximum number to be benefited. And I hope that we will get the this recorded version of all these lectures so that we can very well go again. All the physicians can see and see them again and again so that they can learn many more things. Thank you very much, sir.
Thank you, sir. So I invite every friend here to our DETICON, which is from 8 to 9:30 every day, from 1st to 10th, and then 11th and 12th are our, you can say, physical meeting. Thank you. So any questions or comments? Over to Dr. Parikh, RP Parikh, sir,
Yes,
for
sir.
your...
Thank you very much, sir, Dr. S.K. Sharma, sir, for your lucid and nice talk and taking us through this management of diabetes type 2. We have some panelists over here, and I'll just want a few comments from them. Dr. Anil Mehlawat, can you please join us and give your comments regarding his talk or any queries? Dr. Anil Mehlawat from Junino.
Namaskar, Parikh sir. RP Parikh, namaskar.
Namaskar, sir.
Parikh to Parikh,
हाँ,
Parikh Square.
आपका आशीर्वाद है. Dr. Mehlawat, sir, if he is there.
डॉक्टर मेहलावत साहब आप अनम्यूट करिए, just unmute yourself and just
हाँ यस सर, बहुत अच्छा टाक रहा सर. मेरा एक क्वेश्चन था कि जो कोविड पेशेंट्स हैं,
yes
बताएं सर, कोविड पेशेंट का बताएं.
अनम्यूट करो, अनम्यूट
जो
हो गया.
कोविड वाले पेशेंट्स हम ट्रीट कर रहे हैं, इनमें कौन सी ड्रग्स दें डायबिटीज के लिए? ज्यादातर ये देखा गया था जो पेशेंट्स थे जो नॉन डायबिटिक थे उनके ब्लड शुगर भी ज्यादा हो गए थे, और जो डायबिटिक थे उनके तो बहुत ज्यादा हायर हो गए थे. तो इसमें इंसुलिन के अलावा और कौन सी, जिसके माइल्ड रेंज शुगर थे, उनके लिए कौन सी ड्रग की प्रेफरेंस रखें?
सर, आपके कोविड पेशेंट के लिए मैं थोड़ा सा कमेंट करना चाहूंगा कि जब भी हमारे पास कोविड का पेशेंट आता है तो हमें उसको ट्राइज करना होता है. ट्राइज मीन्स हमें देखना होता है कि ये विदाउट एनी सिम्टम्स है, माइल्ड डिजीज है, और मॉडरेट डिजीज है, सीवियर डिजीज है. पहला तो ये है. सो इम्पोर्टेंट पॉइंट ये है कि जब हमारे पास पेशेंट माइल्ड डिजीज वाला आता है, जिसको हम घर पे ही ट्रीट कर रहे हैं, उनको हमने देखा है बहुत सारे लोगों को स्टेरॉइड दिए जाते हैं, जो कि बिल्कुल गलत है. सो जो पेशेंट हॉस्पिटल में है, स्टेरॉइड सिर्फ उन्हीं को दिया जाना चाहिए. जो पेशेंट घर पे है उनको स्टेरॉइड की जरूरत नहीं होती है. सेकंड मैसेज जो है वो ये है कि स्टेरॉइड का टाइम होता है सेकंड वीक में. फर्स्ट वीक में अगर आपने स्टेरॉइड दे दिया तो उसका प्रोलिफरेशन ऑफ वायरसेस और ज्यादा हो जाएगा और उसको और ज्यादा सीरियस डिजीज हो जाएगी. पर देखने में यह है कि पेशेंट जैसे ही आता है हम उसको देखते हैं कि बहुत सारी ड्रग्स में स्टेरॉइड भी दिया हुआ होता है. तो ये बिल्कुल गलत पैटर्न है. स्टेरॉइड सिर्फ सेकंड वीक में शुरू कर सकते हैं जब आपको लगता है कि पेशेंट को साइटोकाइन स्ट्रॉन्ग होने के चांसेस हैं या सीवियर बहुत डिजीज है और वो हॉस्पिटलाइज होने जैसा है, तब आपको उसको स्टेरॉइड देना है. पहली चीज तो ये है. तो जब मिसयूज ऑफ स्टेरॉइड होगा तो उसको डायबिटीज तो होगी. तो हमारे यहाँ पे देखने में आया कि मिसयूज ऑफ स्टेरॉइड बहुत हुआ है और उसी के कारण म्यूकोरमाइकोसिस हुआ है. एक तरफ तो हमारे डायबिटीज से स्ट्रेस, एक तरफ तो कोविड से स्ट्रेस हुआ, दूसरा कोविड की जो ड्रग्स हैं उनसे इंसुलिन रेजिस्टेंस होता है, तीसरा स्टेरॉइड राइट फ्रॉम द बिगिनिंग दे दिए गए, दैट टू वेरी हाई डोजेस. तो इन सब चीजों से मिलके पेशेंट जो अनडायबिटिक था, नॉन डायबिटिक था, उसके भी डायबिटीज हो गई. सो मैसेज ये है कि स्टेरॉइड को फर्स्ट वीक में देना ही नहीं है. सेकेंड वीक में भी तभी देना है जब आपको लगता है कि वो मॉडरेट टू सीवियर डिजीज में है और उसको हॉस्पिटलाइज करना है. तो फर्स्ट पॉइंट तो ये हुआ. सेकंड ये कि जब आप उसको स्टेरॉइड दे रहे हैं तो ऐसा कोई भी पेशेंट नहीं होना चाहिए जो स्टेरॉइड पे है और इंसुलिन पे नहीं है. स्टेरॉइड मींस यू हैव टू गिव स्टेरॉइड एज वेल एज इंसुलिन बिकॉज नो ओरल ड्रग कैन टेक केयर ऑफ राइज इन ग्लूकोज विच इज कॉज्ड बाय हाई डोजेज ऑफ स्टेरॉइड. ओके. एंड जो पेशेंट हमारे घर पे हैं जो माइल्ड हैं उनको आप मेटफॉर्मिन, DPP4 इनहिबिटर, ये सब कंटिन्यू कर सकते हैं. इसमें कहीं पे भी कोई दिक्कत वाली बात नहीं है. ओनली थिंग इज patient should be instructed to monitor blood glucose more frequently. He should be taking care of his diet and exercise and monitoring more frequently. He should be taking plenty of fluids and taking all those you can say drugs whatever prescribed by the doctor except steroids. That is important. Once you are having a patient in hospital, your patient is on steroid, in second week we will be giving steroids large doses and we will be always treating them with insulin, and this insulin is multiple injections, that is basal bolus therapy. One is long acting insulin, 3 short acting insulin. If the patient is eating his meals every day. If the patient is so sick that he is not eating his meal or he is in ICU, then insulin drip is given. That is insulin infusion drip is given. That is how we treat our patient on steroids. Thank you.
Sir,
Thank
can
you,
I,
sir.
sir, can I add
Before-
just one thing, GD? Sir has explained very well regarding the management of COVID patients with steroids, and so the only recent studies have suggested that we have 3 types of patients. The patients who have pre-existed diabetes earlier, they contracted the COVID, and now they are in the mild form, as Dr. S.K. Sharma sir has told. Please give the drugs which patients were taking earlier. So this is the new studies which says that don't discontinue the drugs. Where whatever the drugs patients were taking earlier, you can even continue those drugs, the pre-existing diabetes. Second, the new onset of diabetes, Dr. S.K. Sharma sahab have very well told, patient in high doses or tapering doses of steroids, give 1 or 2 shots of insulin, and then oral drugs like metformin. DPP-4 inhibitor is of course the drug of choice, but you can combine with metformin, and in the patient is completely stable, even SGLT2 inhibitors can be given. So this is how pre-existing diabetes, and you can differentiate between a new onset of diabetes. This is
Thank
the
you,
only
sir.
idea.
Thank you, sir.
Here,
It's our
Dr.
proud
Bansi
privilege.
Sabu is there.
Bansi Sabu sir is
Welcome to
joined.
Dr. Bansi Sabu.
I request Dr. K.K. Parekh sir to kindly invite Dr. Bansi Sabu for their kind words, sir.
Welcome, Dr. Bansi Sabu. You are most welcome to our coordinator meeting.
Yeah.
Thank you very much. It is
Good
really
evening,
a
Bansi bhai.
gracious presence that we are having in our coordinator meeting
it's all
for the
my
therapeutic
pleasure.
wheel.
It's all my pleasure. First of all,
Thank you,
thanks
sir.
Dr. G.D. Ramchandani for sending me the invitation to join the meeting. I am thanking Dr. K.K. Parekh sir, Chairman of Rajasthan State Chapter, a fatherly figure for all of us, and Dr. S.K. Sharma sir, Dr. Arvind Gupta, and Dr. Pungalia sir, who is coordinating this meeting of, today, from Chittor only. And this program which we have initiated national level at RSSDI, district coordinator, CME program, and primarily the idea is that our RSSDI guideline should become more popular, and more doctors from across the country, even at the rural level, also should use them, and they should treat the patient the way they are treated at a metro city or even tier 2 or tier 1 city level also. So the way it should be treated in the similar way. As we know, the diabetes incidence and prevalence in our country is very, very high, and we don't have so many experts. So the RSSDI primary duty is to it's like a capacity building. We are trying to improve the care for diabetic patients, and how we can do is only if we improve the knowledge and improve the capacity of the doctors, who may be a primary care physician, who may not be the consultant physician. And during our MBBS and MD days, only very few lines are there as far as diabetes treatment is concerned. And that's the reason we are trying to do it. I'm really very thankful that RSSDI Rajasthan chapter particularly taken it in a very big way, and they are conducting many CMEs on this, and each district is taken care individually, personally by Dr. S.K. Sharma and Dr. K.K. Parekh, and with the G.D. Ramchandani is also coordinating with each, and I am also in the group, so I see it very regularly. And I'm sorry I can't attend the full meeting, but G.D. just told me last minute, you please come, and at least at the conclusion you be there. I'm seeing Dr. Kinvasra also. How are you, sir? So
Yes,
thank you
sir.
very much, and once again thanking you, all of you, for inviting me.
Thank you, sir.
Bansi Sahib,
One comment, sir. I would like to
we
say
have,
All credit
comment,
goes
sir.
to Dr. S.K. Sharma, who is almost for last 1 year, more than 1 year, he is disseminating the knowledge almost every day or every other day on some platform.
Sir, I remember
Whether it is
before
Deticon,
that,
whether it is
I-
RSSDI, whether it is insulin workshop. I mean, the person from the Rajasthan and all over India, I can point out one person who is busy almost for last 1.5 years in disseminating the knowledge.
Sir, before
This is
that
really
also,
creditable.
I tell you, before that also, he was doing across the Rajasthan a meeting on gestational diabetes. Once upon a time, I attended his meeting
Yes.
at Jodhpur also. So at that time, he was physically going almost in each district he must have covered, and it was a fantastic program. He improved the care for hyperglycemia and pregnancy for HIP. So I know and I remember, and Dr. Sharma is always there for multiple such programs. So congratulations, sir, Dr. Sharma, sir.
Thank you, sir. Thank you for your very kind
And
words.
all the best wishes for a DTCon 2021.
It is going on parallel, sir. So
Yes,
it
I
was
know,
8
I
to
know.
9 DTCon and 9 to 10:30 is this coordinator meeting.
One small comment, sir, from my side. I would like to share.
Sir.
Can I share one comment?
Yes,
Yes,
Dr.
yes, yes, sir.
Okay.
Yes, sir.
Actually, I'll tell you my story. I also have it COVID. Okay. And after 3-4 days, my temperature was constant and oxygen was 92, 1989. So I asked doctors from Jodhpur and AIMS also. They said me start steroid on 3rd, 4th day, and I got well within 7 days. So they told me if oxygen is coming down to 92, 90, 89, and you have got temperature constantly, you should start steroid on 4th, 5th day also. There's no problem. Usually you start in 2nd week, but if there is problem, we can start early also.
Dr. Khesara, the problem here is what is the first day of therapy, illness is most of the time. So you can say vague that you do not consider that. And then you are counting from a day when you are really sick. That is why I'm saying first 7-day replication of virus is there. That's why it is very important to identify the first day of your illness. Otherwise, whenever you say that I am having very low oxygen saturation, you already finished your first week. That is why they advise you steroid. Mind it. Okay. In general, first 7-day viral proliferation is occurring, and if you are giving steroid, it will be worsening your condition. And
no, they told if the oxygen is coming down to 92, 91.
that comes in the end of the first week, now, because the accurate pinpointing of the illness is really very, very difficult. That is important.
This was my own experience. I don't know how far it is true, but doctor told me you start. So I started and I got well.
Nice. They have given you a correct advice, but once you are having a low oxygen saturation, it means you are having significant illness. And when you are having significant illness, steroids are indicated.
Yes, yes.
I'm not saying that don't give, but what is happening? Patient is coming. I am having fever for the last 1 or 2 days, and steroids are started. And patient is sent
There are
home.
so many other factors responsible for
definitely.
giving steroids. This is not only the oxygen saturation, Dr. Khemsara.
Arvind, correct identification of start of the illness is very, very important.
Yes, that is one thing, and there are other factors like cytokine storm, as Dr. S.K. Sharma have told. It is CRP. It is so many other biomarkers. But if those biomarkers, along with the oxygen saturation, is coming down, and actually what he's saying, the replication is very important. And during replication, if we give the steroids, definitely it will rather worsen the situation.
Absolutely.
So I think most of the time then the patient realizes that is the oxygen saturation is going down, cytokine storm is high, it is already 5 to 6 days. So even on 7th day, we can give steroids very well. There is no problem.
Any other question regarding this?
Sir, I want to comment before concluding, because today's this district coordinator meeting is from Shekhawati area, and there are 3 doyens of Shekhawati here: Dr. S.K. Sharma sir, Dr. Vanshi Sabu, and Dr. R.P. Parekh sir. So they all are 3 doyen of Shekhawati. All are doyen, definitely. So
I like to
बंसी भाई वो कह रहे थे ये मेरा एरिया है, जैसे नागपुर लोग कहते ना ये मेरा एरिया है, मेरे एरिया में कैसे आए?
जीडी मेरे को क्या हुआ पहले के गुजरात से राजस्थान का एरिया में, राजस्थान से शेखावटी में, अभी शेखावटी से कुचामन में, अभी मेरे अभी मेरे मोहल्ले तक लेके जाएगा.
Dr. Panchi, you know,
can I comment, sir?
Please, Solanki sir, please. Solanki sir.
I think Dr. Panchi knows Dr. B.L. Saini. Dr. B.L. Saini is one of the panelists today from Seeker.
Yes, I know Seeker.
So Dr. B.L. Saini, if he is there, he can just say a few words.
Please,
Dr.
please.
Dr. B.L. Saini.
Sir, are you there?
I think he's not there. Dr. Satish Kapoor is there. So I think
Yeah.
he can comment.
Then one question,
Thank
sir. I want to.
चलो सोलंकी साहब आप बताइए क्वेश्चन पूछिए
There is a one question and one suggestion.
सर
Question is because SGLT is a wonder drug for the diabetes and hypertension also, and we are using it in the it is a cardioprotective. As mentioned about this on DTCon also it was mentioned and it was referred that there are some contraindications as well as some the side effects and what are the we should take care about this that it does not cause the ketosis also. And the second suggestion is to Dr. K.K. Parikh, Dr. S.K. Sharma, as you mentioned rightly, that he is working so hard to disseminate this knowledge to the Rajasthan physicians also, and also to, he is so much involved in this. Can't we recommend and can't we proceed for the Padma Award for Dr. S.K. Sharma from Rajasthan?
Thank you, sir. Thank you very much.
Sir, you deserve it, sir. Your social dedication, your social involvement, and your for the physicians also, and for this. Madam, I have not seen any doctor. Dr. K.K. Parikh is a different person. वो हमारे godfather हैं, सब कुछ है.
लेकिन डॉक्टर के
About this clinical work what you are doing.
यदि डॉक्टर परीख साहब रिकमेंड कर दे तो 100% मिल ही जाएगा. सर का इतना
सारा टाइम ये क्लिनिकली ये जिस तरह से कर रहे हैं.
अभी बिरला जी को सर आप अभी तो ऑनलाइन है और ये अभी रिकमेंडेशन आज ही रात को सर आप कर दीजिए सर. It will be pleasure for all of us and for all Indian and all doctors and particularly the community from diabetes community and endocrine community also.
Thank you, sir. Thank you very
much. It will be great pleasure, sir.
Thank you, Dr. S.K. Sharma साहब.
वो पारिक वो
कपूर बोल रहा हूँ.
कपूर साहब बोलना चाह रहे हैं कुछ. कपूर साहब बोलिए.
हाँ, मेरी आवाज आ रही है?
हाँ, बिल्कुल सर, बोलिए.
Thank you, Dr. S.K. Sharma साहब, for nice presentation. मेरा एक क्वेश्चन था. Indian community is having high carbos diet. We are using sulfonylurea, metformin, SGLT inhibitor, DPP inhibitors, but we are using very less AGI. What is your comment?
Absolutely, sir. If you look into the use of AGI, it is maximum in China. You know why? Because they are eating rice, and rice eaters are having very high carbohydrate in their diet. So similarly, as you rightly highlighted, Indian diet is also very high in carbohydrate. And if you are using AGIs, that is alpha glucosidase inhibitor, like Voglibos or Acarbose, they inhibit the absorption and digestion of complex carbohydrate to simple carbohydrate and sugar, and then the glucose curve is flattened out. So postprandial hyperglycemia is significantly reduced. So they usually act on the postprandial hyperglycemia, and their potency is a bit slightly low. And the problem with the AGIs are that there are not significant, you can say, studies in the West. So it is not really highlighted too much, because in West they don't use it because their diet is very high in protein and fat rather than carbohydrate. And then the side effect of these AGIs are that they causes flatulence, abdominal distension, and sometimes diarrhea. And it is an extension of their mechanism of action. And that's why many a times our patients are not happy to have flatulence very frequent. And when you give these AGIs, you have to give it 3 times a day with every meal. If the patient is taking 3 meals, you have to combine them with all the 3 meals. And the another important precaution is it is to be taken with the meal, means first bite of the meal. So sometimes what you see, a combination of metformin and glimepiride and pioglitazone, and which people are taking 30 minutes before meal. So that is really not physiological. These drugs are to be given with first bite of the meal. And that's important. And their potency is something like 0.5 to 0.7%. HbA1c reduction. That too, when you are giving in full doses. And once you give it in full doses, there is a significant flatulence, etc. And that's why many times we see that many of us are not using them as they should be used. You are right. Thank you.
Thank you, sir.
Thank you, sir. There is one question in the chat box. Doctor, we know that we are going to discuss it in the future lectures. But Dr. Narendra Verma asked that when to initiate insulin in type 2 diabetes.
So very important question. Firstly, we will say, as Bansi Bhai is there, that there will be many modules there for this coordinators meeting. This is the just first module. Then it will be followed by like type 1 diabetes module, where we'll be discussing insulin and insulin only. Then there will be diabetic foot, and we can extend it to like complications of diabetes, hospital management of diabetes, and perioperative management. So all those can be discussed in every meeting once we have the completion of the modules which are supplied by Central, or you can say Indian RSSDI. But the question here is when to use insulin. The answer to this question is in two ways. One is sometimes we use insulin right from the time of diagnosis when our patients are coming with very high HbA1c. So patient was diagnosed and his HbA1c is 13, 14, 15, something like that. And at that point, there is a severe glucotoxicity. And to reduce glucotoxicity, drugs are working very slowly. So we usually give insulin, and that to intensify insulin therapy, basal bolus, for a very short time of 2 to 3 weeks or so. And afterwards, once the glucotoxicity is taken care of, patient can stop insulin, and we can give lower doses of oral antidiabetics, and patient sugar profile will remain very good controlled for a very long time. So that is the first important point. In type 1, insulin is the only treatment right from the day 1 to the day end. Okay. But even at the time of diagnosis, we are using insulin. Second is when we are already using 3 oral antidiabetic drugs, or sometimes 4 oral antidiabetic drugs, and patient is still having hyperglycemia. And this is a very common presentation. Long duration of diabetes, 8, 10, 12, 15 years of diabetes, patient is already taking full doses of metformin, sulfonylurea, DPP4 inhibitors, or sometimes even PIO, or sometimes even SGLT2 and then even then patient is having poor control. In Western country, they prefer SGLT2 inhibitor as a first injectable therapy. But in India, we are not preferring it because of the cost of the therapy. SGLT2 inhibitors are injectable at present, and they are very costly. GLP-1 are very costly, and they are injectable one. That's why we are not preferring them. But in our setup, we are using insulin therapy. Like we can continue with oral drugs, and we add a basal insulin, like Glargine or Glargine U300 or Degludec. And then we continue to increase the doses of till a fasting of 100 is available. Then we continue with the oral and insulin. But after few years of also, you find that basal insulin is also not working. Then you require multiple insulin injection therapy. Thank you.
Parik sir, conclude karo. RP Parik sir.
Any more questions? If there are no more questions, I like to thank one and all for attending this meeting, especially Dr. S.K. Sharma sir for his wonderful lecture, Dr. K.K. Parik sir for his presence, Dr. Bansi Shabu sir for his presence, Dr. Arvind Gupta sir for his comments and his presence and always encouraging everyone to speak, and Dr. GD not to be thanked because he is to be there everywhere. If he is not there, a program cannot be held. So GD, definitely thanks to you. And one last thing, that we all should take it seriously, not jokingly, that a Padma Award for Dr. S.K. Sharma, we should, individuals as Indians, we are entitled to nominate him. We should go and nominate on the website, post it, and send the copies to everyone. I think that would be really great for our Rajasthan chapter. And at the end, I thank all of you for attending today's meeting and making it a grand success. Thank you. Good night. Jai Hind.
Good night.
And don't forget to join 8 o'clock daily.
Yeah.